Let's start with a patient. This is the right eye of a 26-year-old female patient coming with pain, redness, decreased vision for the past 1 month, treated as anterior uveitis elsewhere, but on examination, so the patient is taken up for surgery under local anesthesia. Side port is made and you inject pilocarpine to constrict the pupil, followed by injection of intracameral lignocaine, which helps to reduce the mobility of the worm. And then the worm is moved in toto using a Sinskey hook. The inflammatory material is washed out and the AC is formed. And the worm is then sent for a analysis and it turns out to be angiostrongylis. This patient was treated with a combination of topical and oral steroids, but because of the extensive photoreceptor layer loss, failed to pick up vision. So if you look at the number of parasites that can infect the human eye, there's a long list. And they can be broadly classified into those that lives on the human body as an ectoparasites, and those which lives inside the human body, which is called the endoparasite. The endoparasites are divided further into protozoans and helminths. Protozoans are unicellular organisms, and the most well-known of that is Toxoplasma, which has already been extensively discussed today. So this talk is going to focus on helminthic infections, which includes the nematodes or the roundworms, the tapeworms, and the flukes. So how does these worms enter into the human body? So there are many routes through which they can enter the human body, mainly the fecal oral route, where even for the contaminated hand or contaminated food and water, they can enter the human body. Some of them may directly enter, as in case of a hookworm, or they may be transmitted by the bite of a vector, like dilophilairiasis and microfilaria. You can also acquire an infection by eating raw meat or fish, which has been or poorly cooked meat or fish, which has been infested with the larvae. And once inside the body, they will travel from the gut to different parts of the human body, including the eye, but they can produce damage by different mechanisms. So one of the mechanisms is a direct damage, a mechanical damage. You've seen JB Sir's case, where it can actually produce holes in the iris. Similarly, cysticercus larvae can actually produce a hole in the retina and resulting in a retinal detachment. They also secrete toxic products which can be damaging to the ocular tissue, and the human body mounts a severe immune response which can also add to the damage. And if you look at the different manifestations of these different ocular parasite, it is very, very, very varied. So any part of the human eye can be affected by ocular parasite, right from the lid to the orbit to the conjunctiva to anterior and the posterior segment. And depending on which part of the eye is involved, the patient can present with very varied signs like double vision or proptosis, anterior uveitis, loss of vision, hypopyon. The presentation is so variable. So how do we diagnose parasitic infection? So you can divide it broadly into clinical, imaging, lab tests, direct microscopy, and histopathology. Excuse me. So coming to clinical examination, probably parasitic infection is one of those uveitis where clinical examination and history taking, scores over every other diagnostic modality. Coming to the history, parasitic uveitis generally present with symptoms which are kind of similar to other uveitis or other ocular problem. Like I said, it could be proptosis, it could be double vision, or they could just present with pain, redness, and photophobia, loss of vision. But once in a way, a patient might tell you that, I can feel something moving in the eye, and that's not to be dismissed. It's also very important to pay attention to the patient's diet, socioeconomic, and travel history to identify risk factors for picking up a parasitic infection. And the next and the most important part of the examination is the clinical examination. So it's not enough that you do a slit lamp and a IO. You really need to do more detailed examination, including gonioscopy and sometimes examining the anterior vitreous face very carefully. So I'll talk about the second case, which is a 65-year-old female who has been referred as intermediate uveitis in the left eye with pain and blurring of vision for the past 8 days. So in the anterior segment, she has 2+ cells, DM folds, moderate vitritis. But my colleague actually looked at the anterior vitreous face and saw this thread-like structure here. And you can see it's a very active motile worm in the anterior vitreous. Okay. So this patient was taken up for vitrectomy, but unfortunately the worm was eaten up with a cutter. We couldn't identify it. So we managed with a combination of oral albendazole, oral and topical oral steroids, and the patient did very well. At post of 1 month, the eye is quiet and the vision had improved to 618 in spite of the presence of a cataract. So this is what, early diagnosis makes a lot of difference. So you should also be very aware of the common clinical patterns which are produced by some of the common parasites in your area. So one of the commonest things parasitic infections we see in our part of the world is DUSN, in spite of which, it is also commonly misdiagnosed as posterior uveitis or multifocal choroiditis. So the DUSN in the early phase, has a picture which is entirely different from what it looks like in the late phase. And what characterizes DUSN is the presence of these deep retinal infiltrates, which are arranged in the form of cluster or tracts. And you would see a live worm only in about 25 to 39%. That's all. And sometimes you see a combination of lesions which have resolved and, cluster which is active. And you need to look for the live worm near the areas which are looking active. If you fail to identify DUSN in the early stage, you will inevitably end up with a loss of vision in that eye. And DUSN is more common in children and young adults. And the worms can last in the fundus for live worm can last up to 3 years. The ocular toxocara, which is caused by Toxocara canis or cactus, which is a nematode worm. It has 3 typical presentations. So classically, the commonest presentation is a peripheral granuloma. And you often see this band which is extending from the disc to the peripheral granuloma. Sometimes you get a posterior pole granuloma. And sometimes, the inflammation is so intense, it can mimic a endogenous endophthalmitis. And coming to ocular cysticercosis, now this one is caused by the bee for the poke tapeworm, Tinea solium or Tinea saginata. And the larval cyst, the clinical features will vary depending on which part of the eye is involved. So in our part of the world, the literature from India says the ocular adnexal involvement is more common, but in the West, it tends to be more of intraocular cysticercosis. And when the conjunctiva is involved, you can get this conjunctival mass. When orbit is involved, you can get proptosis as well as diplopia. And this is cysticercus inside the vitreous, and this is a subretinal cysticercosis. Coming to the role of imaging, when you cannot identify a worm in the eye, and when it's not visible or the media is hazy, or it's in a location, where you cannot visualize it, imaging is very important. For example, the ultrasound here, it shows a cysticercosis. You have this hypoechoic space with a echoic spot here representing the scolex. It's also very useful in picking up complications like retinal detachment. Similarly, MRI is useful in orbital or cysticercosis, which involves the muscle. Also very important in ruling out neurocysticercosis. So unlike a lot of infectious disease, in parasitic diseases, the lab test, offers only very supportive information. So the complete blood count sometimes may show eosinophilia, but usually they turn out to be normal. You can check the blood and the stools for the presence of microfilaria or exolarvae. And serology, again, can offer supportive evidence or supportive role in the diagnosis of toxoplasma or toxocara. Now, once you have seen a live worm or cyst, if you manage to identify it, you can treat it more appropriately. So the commonest thing you do is a wet mount microscopy to study the morphology of the worm. So to this, it is important that you try to remove the worm in toto whenever possible, and also try not to damage the head and the tail, because that is where most of the characteristic features are seen. The other test which you can do is a scanning electron microscopy, which offers such beautiful details. So this is a Gnathostoma spinaegerum. You can see the head here, and it shows this is the electron microscopy showing all the details and all the characteristics of the spine. Just see the details here. And these details are very important in identifying the worm. Sometimes you have to use DNA techniques and histopathology, and this is a classical case. This is a publication from Aravind Madurai by Dr. Ratnam Madam, and it shows the histopathology of a trematode-induced granuloma, which has been confirmed to be a trematode fluke called Procerovum varium, okay? And the confirmation has come from DNA testing and blast analysis. So PCR techniques are also used in identifying helminthic infections. Coming to the management, it could be medical, laser or surgical management. Medical management is usually by using a combination of antihelminths, usually combined with systemic steroids. So I'm not going to go into a lot of detail, but if you look at this chart, you can see that the one name which stands out is albendazole. So this is an all-rounder, pretty much useful for treating varying helminthic infection, except for filariasis, where diethyl carbamazine is the drug of choice. And for threadworm, it is ivermectin. So this is our next patient, who is a 40-year-old male complaining of defective vision in the left eye with pain and redness since 4 days. This is very similar to the Dusan picture I showed you before, clusters of deep retinal lesion. And these are actually RPE tracks here, these lines here. And here there is a live worm, which is better appreciated in this video. So I would like you to concentrate on this white line here. Do you see it move? Yes. So when you have a live worm, and you cannot actually remove it, you can laser it, laser on the worm and around it. This time they used an argon laser. Plus, you can treat it with albendazole and oral steroids. And this patient, responded really well, vision improving to 6.6 by 6 weeks, by 1 month. Coming to surgical management, we have already looked at surgical management of live or dead worms. You may also need surgery to remove cysts and granulomas, typically cysticercosis cysts, which are in the vitreous or subretinal space, or even trematode-induced granulomas. And for dealing with complications like retinal detachment and epiretinal membrane. And sometimes you may need to go in for getting a sample for excision biopsy. So this is the last video, shows a surgical removal of a cysticercosis cyst in the vitreous cavity. So previously, they used to say that you have to remove the cyst in toto. Otherwise, if it breaks in the vitreous cavity, it will set up severe inflammation inside the eye. But now, the VR expert who did this said, sometimes they don't bother with it. They just eat it up. So that's vitrectomy being done and the cyst is freed. And it's a live cyst. You can see it move in response to both touch and the light. That's the scolex there, that dense white structure. So very active, very, very mobile cyst. So I also asked him, how do you manage to take it out intact? And they said they use a soft tip cannula to get hold of it and bring it to the port, and then it comes out. But previously, since they used to use hypertonic saline, they used to put it in the port, and apparently the cyst is attracted and comes out. Yeah. So before I end, prevention is always better than cure. It's very important to practice hand hygiene and wash and peel, all the vegetables and fruits. So there's some kind of myth that, it's the non-vegetarians who get parasitic infection. But actually, I have worked in the north, and it's actually those who eat raw salad, who usually end up getting parasitic infection. So you have to wash your vegetables and fruits and, thoroughly. Ensure that the food, particularly the meat or fish, is cooked properly. And ensure that you drink only bottled water or water which has been boiled very well. That's my acknowledgement, and thank you for your patient listening.